Hello, since I have just completed video on the hip and shoulder joint, I've decided to also make a video on the elbow joint together with the knee joint. Then I'll make one on the radial ulnar joints together with the tibia fibula. Then of course one will be on the ankle joint and the wrist joint, and the other one will be on the small joints of the foot together with the small joints of the hand. So right now we'll talk about the elbow joint and the rather most complicated joint in the body, that is the knee joint. So we'll start with the elbow joint since it's the less complicated one. Then we'll then finish with the elbow joint, with the knee joint. Do forgive me when I mention the word elbow instead of knee, then knee instead of elbow. Due to the nature of the video, it might happen. So the elbow joint is rather an articulation between the humerus and the radius and ulna. For the humerus, you find that capitulum that actually articulates with the head of the radius. Then you find the trachea that attaches to that trachea process, of course, of the ulna. Then it is actually a hinge joint. Then of course, the knee joint actually also has a hinge joint, but then the one that is formed by that femur and the patella is a gliding joint that is synovial in nature. Then, in terms of the capsule, it is an anterior part and a posterior part. The anterior part actually arising from the coronary and the radial forces that actually are above the 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 capitulum and the trachea. Then from the condyles as well, that is the lateral and medial epicondyles. Then goes inferior to attach laterally on that annular ligament that actually surrounds the head of the radius. Then more medially it goes to the ulna, of course, on that coronate process. Then of course the coronate process receives the brachialis muscle that is an anterior relation actually to this elbow joint. Don't forget that. Then more posteriorly you find that the you find that the capsule will actually attach on the olecranon fossa of that humeral bone. Then more distally it goes, of course, to attach on that olecranon process of the ulnar bone, and then goes as well to that annular ligament that was surrounding the head of the humerus, sorry, of the radius. Then since I've already talked about the ligaments, then we have a lateral and a medial ligament, of course. The medial ligament being triangular, of course, having an anterior and a posterior limb that would then be connected by the transverse limb. So this anterior limb actually comes from that medial epicondyle, then goes to the coronary process. Then the posterior one comes from that medial epicondyle as well, then goes to that olecranon process, and then the two are attached by that transverse ligament. Then you find that the lateral one will arise from that lateral epicondyle, then will actually go and sit on that annular ligament. This annular ligament, of course, surrounds that head of the radius. Then in terms of relations, I've already talked about the brachialis being an anterior relation. Then you have remember we have that cubital fossa. So you also have that median nerve, that brachial artery. Then more laterally, you have that common extensor tendon. Then posteriorly, you find the triceps and the anconeus. These will actually extend this joint. Then you also find medially, you find the ulnar nerve, as it actually courses from that posterior compartment of the upper arm to come to lie on that medial epicondyle, where it can actually be rolled. So in terms of movement, you find that there is flexion and rotation. So take note the movements of supination and pronation, they actually do occur at the distal and proximal radial ulnar joints, of course, affected by the biceps brachii, the supinator. That's for supination. Then pronator quadratus and pronator teres for pronation. However, the supinators are much stronger, so you'd find that when they do make those bottles, they try as much as possible to orient them in a way that supination of the right hand will be the major way of opening them, or the easier way of opening them, since the supinators are much more stronger. Then so in terms of flexion, you find that biceps brachii. Then you also have the brachialis muscle. However, the coracobrachialis is not involved. The reason being, it actually inserts higher up in the upper arm, where you find that ulnar nerve, then piercing the fascial septum to go to that posterior compartment of the upper arm. Then extension, you find the triceps having those three heads of origin, lateral and medial. Then from the infraclinal tubercle, you find that long head, of course, that we did talk about being an inferior relation to that shoulder joint, separating the joint, of course, from the axillary nerve and the posterior circumflex humeral artery, which is a branch of the third part of the axillary artery, together with the anterior and the subscapular arteries. So that's the elbow joint. Then we talk about the carrying angle being 167 in females, then 170 in males. However, this carrying angle does disappear when you fully flex your forearm on your arm. So that's the elbow joint. So we'll now get straight into the knee joint. For the knee joint now, of course, it is those two condylar joints. So you'd find that it's articulation between the femur and the patella, partly for that gliding joint. Then you also have articulation between this femur and the tibia. The fibula is, however, excluded, unlike the elbow joint, where we did talk about the radius and ulnar both taking part. Then so we find that we have those medial and lateral condyles of the femur. Then we also have those condyles of that tibia bone. Then you have that intercondylar eminence separating those anterior and posterior articular surfaces, both of course covered by hyaline cartilage. Then you'd find that you also have intervening menisci, a lateral and a medial one. However, these are C-shaped. However, some texts would sort of differentiate the two, saying that the lateral one is rather O-shaped or circular in shape, deviating from the C shape of that medial menisci. Then this we have two horns that will actually go and attach on the on the medial epicondyle of the humerus, of course having an anterior and a posterior horn, anterior and posterior in relation to the posterior cruciate ligament, one of those intracapsular ligaments of the knee joint that we will talk about in a moment. Then this anterior, of course, will go to the medial epicondyle. Then the posterior will go to that medial epicondyle as well. These two, they all have fancy names. The posterior one is risk or something. Then the anterior also has another fancy name that I have forgotten, but it's not really of importance. Then so we find that the joint between the femur and the patella is the synovial joint of gliding variety. Then the other one, of course, the hinge joint between the tibia and the femur. Then I've just remembered something. The synovial membrane of that elbow joint is continuous inferiorly with that of the proximal radioulnar joint. I'd forgotten that. I just remembered that. I'm sorry about that. But we're talking about the knee joint now. So in terms of movements possible here, we have flexion and extension. Then you just find that there's that abduction. You also find adduction and so forth. Then in terms of ligaments, we have extracapsular ligaments and intracapsular ligaments. I'll talk first about the extracapsular ligaments, then finish on those intracapsular. That is the cruciate ligaments, of course. So the extracapsular ligaments, we find that lateral ligament, which is cord-like in shape, attaching on distally on that head of the fibula. Then more proximally it attaches on that lateral condyle. Then the medial one is flat, attaches on that medial condyle, of course. Then the medial one is actually adherent to the medial menisci. Then the lateral one is separated from the lateral menisci by the intervening tendon of the popliteus muscle, the muscle that is actually involved in unlocking the knee joint. So in terms of when you fully extend, just before full extension, you actually lock the joint when the femur is medially rotated on the tibia. However, when you want to initiate now flexion, you have to unlock this, and this unlocking accomplished by lateral rotation now of this femur on the tibia, being done by that popliteus muscle that arises from the lateral condyle of the femur, then goes to insert, of course, above that soleal line of the tibia. Then, of course, below that you have the soleus muscle arising there. Then, so I talked about the lateral and the lateral and the medial. Then you find that oblique popliteal ligament, of course, that is an expansion of that semimembranosus muscle. Remember the semimembranosus muscle arising from the ischial tuberosity, then going to insert on the medial condyle of the femur. Then those are the ligaments. I'm neglecting one, but I'll come back. The ligamentum patella. No need to for introduction to that one. Remember the quadriceps femoris having those three fasti, and the rectus femoris forming that quadriceps femoris that goes to attach on that patella bone. Then the central part of the tendon then continues distally to that tibial tuberosity as the ligamentum patella. Then intracapsular ligaments. Now you find the posterior cruciate ligament and the anterior cruciate ligament. For those who closely follow football, you will know that these injury to these will actually require surgery, and recovery will be up to 6 months for those sportsmen. Then the mnemonic here is limp. Lateral A, the anterior cruciate ligament. So the anterior cruciate ligament, anterior being in the sense of its attachment to the tibia, then goes to attach. So anterior goes upward, backward, and lateral, right? Then MP, medial, that's the posterior one, goes backward, forward, and medial, right? Easy, they cross, right? These are the intracapsular ligaments. So what I was going to talk about here. Then, so injury to these actually will require surgery, as I have mentioned. Then in terms of I wanted to talk about okay, I'll come back to it when I think about what I wanted to say there. Then in terms of relations, of course, posteriorly to this joint, I know that anteriorly find that prepatellar bursa, the prepatellar bursa more common, forming that clinical sign of what do you call them, housemaids knee, or houseworkers knee, for those who actually spend most time kneeling down, mopping floors and so forth. Then it can be inflamed. Then the superficial infrapatellar will be the Clegg, will form the clinical sign of Cleggiman's knee. Remember Cleggiman's, the pastors, the fathers and the brothers and sisters, of course, at church, they will actually spend time on their knees. And I'm not saying it's bad, but it's just a clinical presentation that most people present with, or rather they will just ignore it. Even for most of us, if we spend most time kneeling down, we'll see some of these things. Then, so talking about these base, you find that we have that prepatellar and the oblique popliteal ligament, of course. Then so the suprapatellar and the prepatellar will always communicate with the joint. Then the semimembranosus bursa may communicate. Then we find that there are 4 bursa that we find anteriorly, then 6 posteriorly. The anterior ones, of course, we have the name patella. Within them we have the superficial and the deep patella, infrapatellar. Then you have a suprapatellar that is beneath the tendon of the quadriceps. Then you also have the prepatellar that is between that is subcutaneous, in that subcutaneous tissue that I talked about there, the houseworker's knee. Then the superficial infrapatellar, of course, will form that what do you call it, the Cleggiman's knee. Then in terms of nerve supply to the joint, you find the femoral nerve, you find the sciatic nerves, the sciatic nerve branch, that's the common peroneal and the tibial part, as well as the obturator nerve. I did talk about the obturator nerve referred pain from the hip joint actually presenting as pain in the knee joint. Then I did neglect the the nerve supply to the elbow joint, that is the radial, the musculocutaneous, the ulnar, and the median nerve, the four of them. So there is four for both. Then in terms of in terms of the movements that are possible at these joints. So for flexion, you find the muscles from the hamstring compartment, the semitendinosus, the semimembranous, the biceps femoris, as well as being assisted by the sartorius and the gracilis, those pes and serous muscles. These pes and serous muscles, that's the semitendinosus, the gracilis, and the sartorius. So actually also have and the action of medial rotation and lateral rotation is from that biceps femoris, of course, that goes to attach on that lateral head of the or that lateral bone of the leg, that is the fibula. Then in terms of flexion, you find that quadriceps quadriceps femoris. Then in terms of relations, of course, medially you find those pes and serous muscles. Laterally you find the common peroneal nerve together with the biceps femoris. Then posteriorly, anteriorly find that prepatellar base, of course, that is subcutaneous. Then posteriorly find those things that are in that popliteal fossa and these boundaries. Remember, there's the semitendinosus, more medially semitendinosus, semimembranosus, and biceps femoris. Then the lateral and medial heads of the gastrocnemius. Then you find the nerves that arise from the sciatic nerve. You find the popliteal vessels. You find popliteal lymph nodes and so forth. Those will actually be the posterior relations of this knee joint. So that's just about it. Thank you very much.